The consequence of all of this activity and our growing population of survivors is we've had alongside it a growing population of consumer advocates. And our breast cancer survivors have been lead among these, demanding better care, demanding involvement in that, demanding more funding out of the government to meet the needs of what they feel are epidemic proportions of individuals developing cancer. And it is really their compelling and effective advocacy that in 1996, the Office of Cancer Survivorship was established at the National Cancer Institute in recognition of the growing population and the fact that we knew very little about the outcomes and needs of these individuals. The ultimate goal of the office is to improve not just the length of survival, because we see those figures are going in the right direction, but also the quality of that survival. What are the health outcomes? What are the health behaviors? What are the economics of individuals who are living long-term following that? Importantly, what it did is it created a home at the NCI for research addressing this part of the cancer control continuum. Looking at individuals in particular, its original mandate was to look at survivors who were 5 or more years out of treatment. So the portfolio that the office holds is of studies looking at individuals at a minimum of about 6 months beyond their definitive therapy. And any time after that. It does not include studies looking at recurrent disease or end of life, which is housed actually somewhere else in the NCI. So if you think of the definition of survivorship that I told you we embraced before, when we look at our research portfolio, it actually excludes the active treatment and end of life component of it. We also have a mandate to educate healthcare professionals who are caring for these individuals, whether they are oncology specialists or community physicians, family practitioners, internists, et cetera, nurses, social workers, psychologists, anybody who may come in contact with individuals with a cancer history. And in some ways, my being here today allows me to fulfill one of those goals by sharing with you the information that we're gathering. And this is your office, so I'm going to remind you about that. This is a federally funded office. We are responsive to your requests and needs. If you think there are things we aren't doing and we need to be doing, you need to let us know that. This is your office. So what I said earlier was when we talk about survivorship research, we really do restrict this. When we think of it, it's really to examine, prevent, and control the adverse outcomes post-treatment. It's not necessarily during, but it's really looking at that post-treatment arena. It's also these last two, the 2 and 3, to provide a knowledge base about optimal follow-up care. This is one of our newer mandates. So what should be the frequency of visits, to whom our survivors should they be referred, what kinds of tests and procedures need to be done. And importantly, and driven in part by survivors themselves, is this third initiative here, and that's really optimizing health. You know, it used to be enough that we thought, certainly when I started in this field many years ago, back when there were a lot fewer treatment options and not very good supportive care and pretty grim outcomes for a lot of individuals, and you didn't talk about it, by the way. We didn't have poster children like Lance Armstrong being public about it. It was still the big C and talked about not in family circles even sometimes. But this issue of optimizing health later is this whole new arena that we've almost stumbled upon. And what our survivorship community is telling us actually is it's not enough that you now treat me and street me, so to speak, treat and street, but now we want you to tell us how to take better care of ourselves. So this is really a new pressure on all of our delivery systems to do primary prevention, secondary, tertiary, and some of us would call it quaternary because you're trying to prevent new secondary cancers in here that may be a risk factor subsequent to treatment. So we have this new look at this, and some of us would argue, you know, we can't think of the cancer control continuum as a flat bar any longer. For our cancer survivors, once their treatment is over, they get looped back again. So you bend that back, and they're back in the prevention, screening, treatment, again, cycle until such time as they have a disease progression or they exit it for some other reason. So we can't think of people sectored out on a continuum, in particular for our survivors.